Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover the acute complications of diabetes mellitus patients. So the first complication that we're going to review is going to be diabetic ketoacidosis. For the etiology, remember that this only happens if there's severe insulin deficiency, and that's the reason behind its appearance in type 1 diabetes mellitus patients. Remember that this can also be the presentation of these patients, and you may diagnose type 1 diabetes after a diabetic ketoacidosis episode. Now for the triggers, it is usually related to changes in insulin therapy, but the most common are going to be the stress for the patient, such as infection and emotional stress, or putting the patient into surgery, or excessive alcohol consumption. Now the pathogenesis is you don't have insulin and you're adding, there's no insulin and you're adding glucagon and epinephrine responses in the patients that unfolds as a hyperglycemia, and that puts the patients into osmotic diuresis, increased osmotic diuresis, and that can cause dehydration. Now, there's also ketone body production, and that is because of the lack of inhibition of the hormones sensitive lipase, because insulin usually inhibits these lipase, so you're going to have increased lipolysis, increased free fatty acids, and you're going to start generating ketone bodies. The ones that you produce are going to be acetone, acetoacetic acid, and beta-hydroxybutyric acid. This is going to cause an increase of the anion gap, and it's going to cause metabolic acidosis. Now, patients are also reported to have hypertriglyceridemia, and it is in relation to having no insulin and also a downregulation of the lipoprotein lipase, and that is going to increase your triglycerides. And now your signs and symptoms are going to be in relation to the dehydration, to the production of ketone bodies, and of course the metabolic acidosis. So patients are going to present with anorexia, nausea, vomiting, abdominal pain, and a fruity breath odor due to the lungs getting rid of the acetone. And also dehydration is going to present with signs in the skin and the mucous membranes with dry skin, dry mucus, and lower skin turgor for the patients. Patients may also present with altermentation, and they can progress to coma. And since the patient has a metabolic acidosis, the lungs are going to try to get rid of the acid through increasing the respiratory rate. And of course, they are also getting rid of some ketones such as acetone, and that is going to present as rapid breathing and a sign commonly known as cosmal respiration. And so moving on to the diagnosis, remember that these patients are going to present with hyperglycemia, and usually around 200 to 1,000 milligrams per deciliter. Of course, the increased anion gap in these patients and the metabolic acidosis. Of course, patients can develop dilutional hyponatremia, and we are going to teach you how to assess that in a minute. And of course, patients are also sometimes reported as hyperkalemic, although patients may be potassium depleted. This is because the acidosis promotes a cellular exchange of protons for potassium, and so the patient may appear as hyperkalemic, but remember that these patients may develop dehydration and an increased aldosterone response that is going to promote depletion of potassium. So keep that in mind for the treatment. Also, you can assess ketone bodies either in the blood or in the urine. And now for the treatment, the first thing that you need to do is to rapidly hydrate your patient with IV 0.9% saline to get rid of some of the symptoms. Of course, giving an IV insulin administration to the patient to get rid of the metabolic disturbances. And there are some guidelines that you need to follow. You have to first correct the sodium. Remember that we told you that it was a dilutional hyponatremia, so it is around 2 milliequivalents per liter for every 100 milligrams per deciliter of glucose over 100. So that would be if a patient has 500 milligrams per deciliter of glucose, then you should correct for the 400 milligrams that is over 100. The first ones are normal, then you should correct for the 400, and that would be around 8 milliequivalents per liter that you should add to the sodium, and that would correct for the dilutional hyponatremia. Now, remember that insulin has an effect on potassium. It lowers potassium. And remember that we told you that these patients are potassium depleted. So you have to avoid generating hypokalemia in these patients. And if the patient already has a potassium less than 5.3 milliequivalents per liter, then you should consider adding potassium. Also, dextrose to 5% is used when your glucose reaches levels lower than 200 or 200 milligrams per deciliter in order for you to avoid generating hypoglycemia in these patients. And lastly, you should overlap the treatment of IV insulin in your patients with subcutaneous insulin, and this one occurs when your patient is already reaching a stable anion gap of less than 12, bicarbonate higher than 15, that meaning it is normalizing, a glucose less than 200, and your patient is able to eat. And now with this patient, remember to overlap the treatment between the subcutaneous and the IV insulin. Now let's move on to the hyperosmolar hyperglycemic state. It is usually seen in patients with type 2 diabetes mellitus because patients have enough insulin to prevent ketoacidosis, but not enough to prevent hyperglycemia. So the triggers for these patients are usually non-compliance with treatment or changes in therapy, and also patients that have not enough water. So elderly patients are the usually affected ones because in them you have this perfect combination. These are patients that are usually non-compliant with treatment and that can not get enough water. So these are the most common patients for this presentation. Also patients that have infections, stroke, diuretics, steroids, and other stressors. Now for the pathogenesis, these patients have an hyper-increased hyperglycemic diuresis, and so this is going to involve as osmotic urinary losses and of course a profound dehydration for these patients. Now for the signs and symptoms, of course, polyuria, polydipsia, patients can develop weakness, confusion, lethargy, seizures, and can develop coma. Now for the diagnosis, remember that these patients develop this condition over an amount of days, so they can reach hyperglycemic levels as high as 600. The diabetic ketoacidosis patients usually develop their hyperglycemia in an amount of hours, so they don't usually get as high as these patients. The serum osmolality is going to be higher than 320, and these patients have no acidosis since they are not developing ketone bodies. Now for the treatment, remember to hydrate these patients rapidly with 0.9% saline IV, and of course electrolyte replacement may be needed. If the patient needs to correct sodium, potassium, or calcium, then check for those. And of course, patient may or may not need insulin, and that is in regard to the patient's presentation, the amount of hyperglycemia that the patient has, and the extent of the dehydration.